Hello again. Welcome to the invisible science of smiles. So today we are going to talk about the big five. In the last episode, we uncovered something most people never heard. Gum disease is not just about losing your teeth. It's a chronic inflammatory condition that can lower the entire system. I promise you that today we will do two things. First, connect the oral inflammation to the big five, which to me are arterial disease, heart disease, diabetes, Alzheimer's, and cancers. And second, we're going to explain why biofilm management is fundamentally different from what most people will call a clean. So let's begin. Before we talk about each disease, we need to understand what they share. So across all the five big conditions, we see chronic low-grade inflammation, metabolic stress, oxidative stress, endothelial dysfunction, and immune dysregulation. Modern medicine does no longer believe in a single cause disease. Disease will develop when the system is overwhelmed by cumulative stressors or risk factors, if we want to call them that way. So the mouth is one of the most vascular, immune-active, bacteria-dense interfaces in the body. What happens here does not stay in the mouth. So let's start with arterial disease. So arterial disease begins with injury to the endothelium. The endothelium is the inner lining of the blood vessels. When they are healthy, the endothelium produces nitric oxide, which keeps vessels flexible and regulates inflammation. When they're injured, nitric oxide will drop, oxidative stress will rise, LDL becomes oxidized, and plaques will begin to form. Chronic periodontal and endodontic infections contribute to this injury through systemic cytokines like interleukin-6 and TNF. Let's talk about heart disease. So heart disease is the clinical outcome of arterial instability. It is fundamentally inflammatory. Components of periodontal pathogens have been identified in arteriosclerotic plaques, and some of the key microorganisms include Porphyromonas gingivalis, Treponema denticula, Aggregatibacter, Actinomyces comitans. These bacteria don't cause heart attacks, but they do activate immune pathways that can contribute to plaque instability and endothelial dysfunction. So dentistry per se does not treat heart disease, but it can reduce one of the inflammatory inputs that can drive it. So the same way, for example, that we have risk factors for heart disease, such as obesity, being overweight, it doesn't mean that if you are overweight or you have a high blood pressure, it's going to give you a heart attack, but it will put you at a risk. So gum disease is another risk factor, same as having dysbiotic biofilms in your mouth. So let's talk now about diabetes. Diabetes and periodontal disease have a bidirectional relationship. Chronic oral inflammation can elevate cytokines, can increase insulin resistance, and can worsen glycemic control. Diabetes, in turn, can increase susceptibility to periodontal destruction. Clinical studies have shown that periodontal therapy can improve HbA1c levels, modestly but significantly. In metabolically vulnerable patients, uncontrolled biofilm can become another weight on the system. So it's really important to treat gum disease if a patient has diabetes. Now let's move to Alzheimer's disease. A lot is being said about Alzheimer's, and the brain is extremely sensitive to inflammation. So chronic systemic inflammation can activate the microglia, can disrupt the blood-brain barrier, can promote neurodegenerative processes, and there are certain periodontal pathogens, particularly Porphyromonas gingivalis, which have been implicated in Alzheimer's-related inflammatory pathways. Again, we are not talking here about causation because it's impossible to know whether there is a special microorganism that is going to cause a disease. But contribution to inflammatory load is actually something that can happen because the brain doesn't live in isolation from the mouth. So cancer is at number 5. So cancer thrives in inflammatory environments. We all know that. There is one oral pathogen that deserves attention here. It's only found in the mouth and is called the Fusobacterium nucleatum. This microorganism is associated with periodontal disease and also oral dysbiosis. When it's swallowed, it can survive transit under certain conditions. There are some specific subspecies of this Fusobacterium nucleatum, especially the animalis, which are enriched in many colorectal cancers, and they have been seen increasingly in pancreatic cancers and some other cancers. These strains can activate inflammatory signaling pathways, they can promote immune evasion, they can support tumor microenvironments. So again, this does not mean that gum disease can cause cancer. Gum disease does not directly create cancer cells, but when we have chronic inflammation, there can be a biological environment that might support tumor growth or progression if the cancer is already developing. So again, it's a risk factor and it works as associations. So chronic periodontal and endodontic infections will contribute to this injury through different paths. Systemic cytokines like interleukin-6 and TNF-alpha, bacterial endotoxins, for example, lipopolysaccharides, oxidative enzymes like myeloperoxidase. In preventive cardiology, including the Veil-Donin model, arterial disease is seen as a disease of chronic inflammatory injury. It's not just cholesterol. Several of those root causes can originate in the mouth. Okay, so now let's move to the biofilm management, because this is the critical question. So, if a dysbiotic biofilm can drive inflammation, so what can we do about it? So this is where we need to be very clear. So what we call a clean is not the same as biofilm management. A traditional clean usually focuses on removing calculus, which is the hard deposits on the teeth and under the gums, and polishing surfaces. Biofilm management is different. Biofilm management looks at disrupting microbial communities before they actually get mature, targeting pathogenic communities, reducing inflammatory triggers, and we personalize the frequency based on risk. Biofilm in the mouth starts changing within minutes after we brush. If we left it undisturbed, it's going to mature. And as it matures, its composition is going to change. The virulence is going to increase, and then inflammation is going to follow. And these biofilms can become more destructive. So what we call a clean is basically the removal of hard deposits above the gum line. Biofilm management helps us prevent dysbiosis or try to regain that microbial balance. That is a complete different philosophy. Modern protocols, for example, a guided biofilm therapy by EMS, GBT is what we know it by, are built around systematic biofilm disclosure, targeted air polishing, minimally invasive removal, and patient-specific maintenance intervals, taking into consideration how well the patient can disrupt these biofilms. It also has emphasis in patient education. So it's mostly inflammatory control. For patients with cardiovascular risk, diabetes, implants, or previous periodontal disease, this is becoming the standard of care. I think I can go as far as saying that if we want to prevent chronic inflammation in the oral cavity, prevent bleeding gums, and establish gum disease, biofilm management is also becoming the standard of care. Because in reality, what we're trying to control with biofilm management is what we can see in the mouth. And that difference really matters, especially over the years of decades, and also when we are talking about longevity. Another technology that is becoming very important is laces. In deeper infections, sometimes mechanical disruption alone is not enough. This is where precision tools have a place. So this technology is becoming quite important in the treatment of gum disease. Laser-assisted therapy is not about burning or cutting tissue. In some instances, this might be necessary. But what we try to do with lasers is to be more conservative. But lasers can help us to reduce bacterial load where instruments struggle to reach. It also helps us to lower the inflammatory burden. It supports healing by increasing the ATP levels in the mitochondria. The treatments can be less aggressive, and it allows us to have more precision. Independent research shows that treating dysbiosis and gum disease can help us reduce systemic inflammatory markers, improve endothelial function, improve glycemic control. What we're trying to do with these therapies is risk modification, so reduce the risk as much as possible. Now, this is very important. We cannot promise immunity from disease. No responsible clinician can guarantee that. But what we can do is to reduce the load, that inflammatory load that is going to cause eventually an event. And then we can help biology to respond to that inflammation. When we are constantly bombarded by new technology, new devices, new promises, it becomes very easy to fall in the trap of thinking that everything must be applied to everybody and every case. That more intervention means better care. But that is not always the case. This is where ethics and evidence-based dentistry protect both the patient and the profession. Yeah, just because we can't do something, it doesn't mean that we should. In the next episode, we are going to talk about these two essential pillars, ethics and evidence-based decision making. And we're also going to talk about something even more important, in my opinion, and is the patient-dentist relationship. I think we as doctors can guide you, we can diagnose, we can treat some of your problems, we can help you reduce the risk. But at the end of the day, health is a partnership, and no technology is going to be able to replace the responsibility that the patient has, and no procedure is going to replace daily choices. This is the end of our episode for today. Take care, and we'll see you in our next episode.